Hello everyone, and I will be discussing the physiology questions in your and Dr. Anupama Chaudhary Devgan. Right, so let's have a look at the first question. Now this says a 50-year-old alcoholic male presents with cirrhotic liver disease and chronic pancreatitis. He has been nauseated for the past several days and not eating. Blood glucagon levels are elevated in this patient. Which of the following is most likely to occur in this patient? So basically, this question is asking you about the physiological role of glucagon. Now, glucagon will be increased whenever there is a decrease in the blood glucose level. A hypoglycemia causes release of glucagon. This increases glucagon from the alpha cells of the pancreas. And what is the role of glucagon? Glucagon will increase the blood sugar level. And how does it do so? It increases, its target organ is the liver. It increases the glycogenolysis in the liver and also gluconeogenesis. This increases the blood glucose level. So my answer to this question will be increased gluconeogenesis in the liver. It also increases glycogenolysis, but not in the muscle, in the liver. What is the action of glucagon on insulin secretion? Glucagon increases the insulin secretion. The second messenger for glucagon activity is cyclic AMP. Glucagon will act on its receptor, increases the activity of the adenylate cyclase, which increases cyclic AMP. So this in fact increases the adenylate cyclase activity. So my answer to this question is B. Let's look at the next question. It says filtration fraction of the kidney can be increased by increase in which of the following? Now firstly, what is filtration fraction? Filtration fraction is GFR divided by the renal plasma flow. GFR divided by the renal plasma flow. Now, how much is normal GFR? Normal GFR is 125 ml per minute. And how much is normal renal plasma flow? This is 625 ml per minute. So that means what is my normal filtration fraction? If you solve this, this is about 0.20, though the range for filtration fraction is 0.16 to 0.20, or which can also be written as 16 to 20%. Basically, filtration fraction of 20% means that out of the entire amount of plasma which flows into the kidneys in unit time, 20% is filtered to form the glomerular filtrate, right? Now, how can I increase the filtration fraction? Filtration fraction, like I said, is GFR divided by renal plasma flow. Now, supposing, let's look at option A. If we increase the afferent arteriolar resistance, if there is an afferent arteriolar constriction, what will happen to the blood flow? Now, this is the afferent arteriole, the glomerular capillaries, and the efferent arteriole. Right, and this here is the Bowman's capsule, right? Now, if I increase the afferent arteriolar resistance, that means less flow into the glomerular capillaries. So what will happen to the hydrostatic pressure? There will be a decrease in the hydrostatic pressure, which in turn will decrease the GFR. And if the GFR decreases, if the numerator here decreases, what will happen to the filtration fraction? Reduces. So this is not my answer. What if I increase the efferent arteriolar resistance? Now, if I increase the efferent arteriolar resistance, if I cause a efferent arteriolar constriction, then flow of blood from the glomerular capillaries into the efferent arteriole will be reduced. In other words, it creates a back pressure. And because it creates a back pressure, efferent arterial resistance will increase the BGC and therefore increase the GFR. Increase the BGC and increase the GFR, right? And at the same time, what is it going to do to the renal plasma flow? Now, remember, each kidney has got 1 million nephrons. So if I cause an efferent arterial constriction of all these 1 million nephrons, the total renal plasma flow will decrease, right? The total renal plasma flow will decrease. So in this case, by causing an efferent arterial constriction, I am increasing the numerator and decreasing the denominator. In other words, what is going to happen to the fraction? The fraction will increase. So my answer to this question is efferent arteriolar resistance. If I increase the efferent arteriolar resistance, I'm increasing the PGC, increasing the GFR, but at the same time reducing the total renal plasma flow, resulting in an increase in the filtration fraction. If I increase the Bowman's capsule hydrostatic pressure, remember Bowman's capsule hydrostatic pressure, if I increase this pressure opposes filtration, so GFR will reduce. If I increase the plasma oncotic pressure is also a force which opposes filtration, so this will also reduce the GFR. So my answer to this question is B. Let's look at the next question. Which of the following is the primary physiological stimulus of gallbladder contraction during the digestive period? Now, basically, I'm trying to ask you is what is the most important stimulus here? Now, for gallbladder contraction, cholecystokinin is the most important. So, what is going to be the primary physiological stimulus? This is a fat-induced release of cholecystokinin from the small intestine. Now, what is a cholegog? Cholegog is anything which causes a contraction of the gallbladder. And this is primarily cholecystokinin and whic. These are the two cholegogs. They increase the contraction of the gallbladder and therefore contraction of the gallbladder and therefore increase the secretion of bile. Next, a 42-year-old woman with lightheadedness and recurrent syncope is taken to the emergency where she is given atropine. Her symptoms are relieved by an increase in which of the following? So basically here is a patient of lightheadedness and recurrent syncope or syncope is taken to the emergency where she is given atropine. So we really do not know what is the reason for her syncope or syncope. We can possibly, since she's been given atropine, so that means probably it is increased parasympathetic discharge, or it could be where maybe, she has taken some sort of acetylcholine agonists, such as muscarine. Muscarine is present in certain types of mushrooms. So acetylcholine agonists, such as muscarine, probably has given rise to a decrease in heart rate and lightheadedness and syncope. So a symptom, when we give atropine, her symptoms are relieved by an increase in which of the following? The moment you give atropine, it blocks the action of acetylcholine and thereby increases the heart rate. Now, what about PR interval? If there is an increase in PR interval, if there is an increase in heart rate, PR interval will decrease. Stroke volume and ejection fraction, these are not affected. Remember, there is no vagus to the ventricles. So stroke volume and ejection fraction are not affected by parasympathetic. So basic action over here is the atropine blocks the action of parasympathetic on the SA node, and this in turn causes an increase in heart rate. Let's look at the next question. A 30-year-old woman is admitted to the emergency with dyspnea, tachycardia, confusion, and other signs of hypoxia. The following laboratory data were obtained when the patient was breathing room air. PaO2 is 67, which is definitely reduced. Saturation of hemoglobin is 90%, which is reduced. Normal PaO2 should be 95 millimeters of mercury. Normal saturation is 97 to 98%. PaCO2 is increased. Normal is 40 millimeters of mercury. pH is 7.27, which is reduced. So this is respiratory acidosis. Bicarbonate levels normally is 24 milliequivalents per liter. Hemoglobin is normal. The partial pressure of oxygen in the venous blood is 30. Saturation of venous blood is 55. Oxygen consumption 350 ml per minute, and the oxygen content in the arterial blood minus the oxygen content in the venous blood is 7 ml per 100 ml. Which of the following is the most appropriate classification of the patient's hypoxia? Is it a hypoxic hypoxia, anemic, stagnant, or histotoxic? Now, very importantly, we must understand now what happens in hypoxic hypoxia. In hypoxic hypoxia, there is a decrease in the PO2 and a corresponding decrease in saturation. So this clinical picture is corresponding best with hypoxic hypoxia. What about anemic hypoxia? Now, anemic hypoxia could be due to a decrease in hemoglobin, but here the hemoglobin is normal. Or it could be possible that there is a decrease in the hemoglobin saturation, as you see in carbon monoxide poisoning or in methemoglobinemia, right? So anemic hypoxia, it could be due to decrease in hemoglobin or a decrease in saturation, right? But the important point here is PO2 is normal, right? So here the hemoglobin is normal, so this is not likely. Saturation is reduced, but the PO2 is also reduced, right? In anemic hypoxia, PO2 should be normal, so this is not anemic hypoxia. What about stagnant hypoxia? In stagnant hypoxia, the important thing is that in stagnant hypoxia, like for instance, which is brought about by cardiac failure, we expect that what should happen to the arteriovenous, the difference in partial pressure in the arterial and venous blood, this in stagnant hypoxia is increased. In histotoxic hypoxia, decreased, right? So the venous blood, the arterial blood here is 67 and the venous is given as 30, a difference of 37. Yes, normal difference is about 55 millimeters of mercury, right? So here's in stagnant hypoxia, we expect that this difference has to increase, but this has not increased. Therefore, this is unlikely to be stagnant hypoxia. Histotoxic hypoxia, the difference in partial pressure of oxygen in arterial and venous blood is, it should be reduced. But like I said, in that case, the arterial PO2 should have been normal, but here the arterial PO2 is reduced. So this is unlikely to be histotoxic hypoxia. So here my best answer is hypoxic hypoxia. My email ID is Dr. Anupama Devgan at gmail.com. Any questions, any queries regarding this grand test may please be, you can send me a mail and I will try and address them. Thank you so much.